On behalf of my co-chair, Ruth Leidenstein, it's my pleasure and I'm honored to chair the final session of this symposium. In this wonderful symposium, we have seen a fine balance between the disease and the patient behind the disease. And so it's only consequent that the last session is again focusing on the patient behind the disease, and we will deal with late effects and quality of life. Ruth has asked me to introduce the first speaker, Miriam Goethe, now working in Essen. She's a sports scientist. She wrote her doctoral thesis under supervision of Joachim Boos, pediatric oncologist at Münster University, who's a professional sportsman and skier in this other personality, where he built up a sequence of skiing activities in pediatric patients. And Miriam Goethe, as a result of her dissertation, she was very active in building up a network of active onco kids, where you allow and encourage the cancer patient and the young and adolescent cancer patients to be as active as possible during treatment and after treatment, under professional supervision, under professional guidance. Miriam Goethe, the chair, the floor is yours, and we are looking forward to your presentation.
Thank you, Henry. Nice to be here with you. So give me just a second to start my presentation. Okay. So, yes, my presentation is about physical activity and exercise under the hashtag Let's Move. So if your legs are tired, don't hesitate to get up and move during the talk. I want to mention the first problem I want to talk about, and this is inactivity and sedentary behavior. And we know from our own results and other studies that young patients are quite inactive during treatment and after treatment. And based on a survey we did back in Münster, 50% of young patients are in bed for 23 hours per day, or even more during hospital stays, meaning less than 1 hour out of bed. So we have to ask ourselves the question, is usual care, including physical therapy, not sufficient or not effective or not enough to get patients moving? We further know that physical inactivity exacerbates many side effects of cancer treatment, like fatigue, depression, and physical deconditioning. So we should think about how to get our patients moving, like this little boy here. And you might ask yourself, what is the evidence about the effects of exercise? And we know from large epidemiological trials that exercise is able to prevent some cancers, including breast cancer, colon cancer, or even reduce the probability to get those cancers. We further know that it is associated with better survival in 3 common cancers. And we know, and this is a very important point here, that exercise for cancer patients can reduce fatigue, can improve quality of life, improve physical functioning, and reduce anxiety, depression, lymphedema. And we have strong evidence for this and for these endpoints in adult oncology. But in pediatrics, we have less evidence, but we have first, based on meta-analysis and reviews, we know that in pediatric oncology and young adults, we have also effects on fatigue, quality of life, and physical fitness, and also body composition. I want to talk now a bit more in detail about Ewing sarcoma and physical activity. And I want to point out 4 aspects. And the first aspect is that physical activity is reduced. And this is an example. This was a large study from the group of Uta and Heribert, where they analyzed Ewing sarcoma survivors. And as you can see here, the survivors are more low active and more sedentary or somewhat active, and control subjects, meaning healthy peers, are more likely active or highly active, and more a higher percentage of them is achieving the recommended 10,000 steps per day. We further know that physical functioning and quality of life is reduced, and I'm quite sure that Gabi Calaminos is going to talk about this later. And the third point is that exercise intervention are feasible and safe, based on a national study we conducted within our network. We came to the conclusion that exercise is really safe, because based on 35,000 exercise interventions, only 6 adverse events graded 2 or 3 were reported, and the most serious adverse event was a bone fracture, which is not nice, but not really life-threatening. And the fourth point is quite an exciting one, I think. There is first evidence that highlights positive effects of exercise intervention on chemotherapy efficacy through vascular modulation. And you can see in this figure, this was experiments in mouse models. The upper lines are mice who received no intervention or doxorubicin alone. And this line are mice who exercised. And this line are mice who exercised and received additional doxorubicin. And this line, as you can see here, was associated with the less tumor increase, meaning that it might be really true that exercise not only influences quality of life and fatigue, which are very important points, but also is associated with better treatment efficacy. You might ask, if evidence is limited, why should we start implementing exercise programs now already? And sometimes pictures say more than many words. And we know that exercise is fun for the patients, that patients are isolated from their club and recreational sports. We know that exercise is very low risk with high potential of effectiveness. And we know that exercise and physical activity are very important aspects of general health and motor development. And this is why just recently we published a consensus guidelines on movement and exercise in pediatric oncology, also focusing on young adults. This was led by the Network Active OncoCats Heribert, already mentioned. We are a working group in the German Society for Pediatric Oncology and Oncology, and we developed 11 recommendations that include rights to be physical active, that include some framework conditions on how to implement exercise, and recommended also some interventions to reduce side effects where we have evidence. And this is what we do in Essen. We have exercise programs during the whole cancer trajectory, beginning at the moment of the diagnosis, and following the patients through the treatment with individualized supervised exercise sessions during treatment, and more group programs and sport camps, reintegration approaches during survivorship. We always include the parents via counseling and behavioral change approaches. And of course, we have some research going on to close those research gaps that still exist for those young patients. We also have first cooperations with health insurance companies because as always, it is important to have the funding for those additional supportive programs. Those are just some examples for exercise during treatment. We have a young lady with a bone tumor doing some balance exercises during her chemotherapy cycles. We have a young boy after tumor surgery that is trying to get active again, and he loves to play football. And we have another boy that is just trying to be active and having fun. Exercise off treatment, of course, is different. We have different collaborations with sport clubs. We have a focus on nature sports, to be outdoors, to feel the wind and the water, and to have experience that are more based on daily activities in normality. And those are pictures from, yes, all sarcoma patients. And you might not see on the first view that this girl is having amputation of both lower legs. And you cannot see that this girl is having an endoprothesis in the shoulder and upper arm. And we have young patients windsurfing with rotationplasty and endoprothesis devices. And this is always an important point when we, from an exercise and movement perspective, talk to the patients, that also local therapy is relevant for the possibility to engage in exercises. We have the largest amount is receiving endoprothesis, and we have very good activities of daily living, but we have limited ability for high impact sports. And sometimes this is a problem for those patients. And we even talked to patients that are happy with the amputation because they are able to engage in highly competitive Paralympic sports. And I just want to say that it's important to have an interdisciplinary exchange, and that the patients need to know what they can expect after the surgery. Because based on our study, we concluded that most patients, meaning 80% of bone tumor patients, do not participate in physical education after completion of therapy. And this is, I think, an amount way too large. And the problem is not always that the patient is not able to do this, but the teachers are sometimes anxious and don't know what to do. So our network again tries to help those teachers to get more information about what they can do and maybe what they shouldn't do. And this is my summary already. Many research gaps exist, but sufficient arguments are available to get patients moving. We know that exercise is feasible and beneficial from diagnosis to off-treatment phase. We should always find individual solutions more than standardized training protocols because everyone is different. We should always include interdisciplinary meetings with oncologists and tumor orthopedics to ensure the safety of exercise, because in some events exercise might be not able, but the patients could engage from upper extremities. And we should further try to implement exercise into usual healthcare systems. To enlarge our research community, we are organizing in April a virtual meeting on this topic. If you're interested, check out our homepage. And thank you very much for your attention.
Thank you, Miriam, for a wonderful presentation. I could imagine that patients in Essen now don't want to go home after treatment. They would rather stay in hospital. Do you find patients continue these exercises they learned during their inpatient stay at home, or do they fall back into inactivity when they're not under your supervision?
Yeah, that's an interesting question. We don't have data on this, but we feel that patients who learn from diagnosis that exercise is possible and that they can exercise, they're not that anxious, and that they engage at home with their siblings, for example. We also have some approaches like virtual exercise lessons, or we have some videos on YouTube where the kids could train from home.
Okay. Any other questions from the audience? If not, so thank you very much for this wonderful presentation. And please, everybody should save the date for your conference. And I pass on the chair to Ruth Ladenstein, who will introduce the next speaker.
Thank you very much, Heribert. And it's my pleasure to introduce Gabi Calaminos. I think she does not need an introduction because she has a very well-known international standing in many roles. So it's my real pleasure, Gabi, to now introduce you and to have your talk on quality of life, which indeed is more than questionnaires. Please.
Yeah, thank you, Ruth, and thank you for the organizers, of this meeting, that have the ability to talk about this topic as well, which combines a lot of this what we have already heard. And I can directly connect to Miriam's talk because physical functioning here is a very important point in health-related quality of life of sarcoma patients. So just to remember, health-related quality of life is a multidimensional construct that embeds physical functioning as well as other things like body image, self-esteem, and psychological functioning and well-being in its whole perspective. And also the ability to move and to be active is an important part of this construct. So if we look into what is already there and what we know about quality of life in survivors or in patients with sarcomas, most of that what we have up to date, and there's quite a lot already in the literature, is on survivors. So in populations who already have undergone treatment, and also there we know for long that to assess this multidimensional construct is not easy. So we have now a longer series and large cohorts that were reported, and all they report that the disease and its treatment, and even also when it's happening in terms of age, has an impact on quality of life of these former patients. This is specifically in some of the dimensions, physical functioning, body image, self-esteem are major fields where impairments stay long, and also, as it was mentioned earlier, fatigue is a problem for long in part of these patients. There were also bigger studies coming from childhood cancer survivor studies, and as well publications, Miriam, related to this in some of the results of the Ewing Sarcoma group that combined the clinical outcome and also physical activity issues on long-term survivors in a huge Ewing Sarcoma cohort. But what is a focus that we have to meet, and I think now a lot of trials are meeting this and trying to solve this, is to have qualitative methods and also methods designs alongside with clinical trials to look in a prospective way how quality of life, health-related quality of life is in patients and how it's developing through the course of treatment. In an ideal world, we would have this already, and this would help us then to get these data into new conceptions of trials, to have defined risk groups for impaired quality of life so that we can plan already interventions, maybe in a kind of future setting, and also that we can use it for individual consultations in clinical care. Maybe also combined with consultations for physical functioning plans. So as we wanted to look at this question in particular, also we did in Ewing 2008 a first attempt, and we focus it as a secondary endpoint. And in my next slides, I will just give some few information about what we could find and what are also the challenges that we have to meet if we are doing this. So in the Ewing 2008 trial, we had fixed 4 time points for quality of life assessment. The first was after the first, or in the phase of the first chemotherapy course, and the second before surgery. And then the third time point was at the end of treatment, which was not in all of the randomized groups the same, concerning the period between randomization and this time point. And the fourth time point was for all 2 years after the end of treatment. We tried to use a quite simple construct. So we used for the under 18 years old the PET-SQL, which is a general measure for children and adolescents. Also with the proxy version for patients, we used the multidimensional fatigue score from the Burney measure, from the PET-score measure, to stay in the same construct. And for functions, we used the TESS, and over 18 years, we used the well-established ERTC, QRQ-30, and the MFE, which is also linked to the ERTC and the TESS. So the study questions we looked at was first, can we say something about how the disease and the treatment affects quality of life? And is there a difference also in terms of sex, age, and randomization status of the treatment groups? So that were the main questions. And we also wanted to look at the impact of the zoledronic acid question in the R1 group. What we have to know is that specifically there are always challenges before you start such an investigation. And when we did this in Ewing 2008, for some countries who were participating, we could not use the questionnaires as there were no validated translation. I think now that the picture is much different, because for the instruments here I raised, now I think there are even all European languages at least, and also the main international languages are there and validated. And another possibility is, another challenge is the participation rate. We always have to see that although we have a lot of patients and registered in a trial, when you have a lot of different randomization arms, it could be that in the end you have quite small groups than in the randomization arms you can really look at. And another point we have to face is that we do not have a kind of, you can say, general quality of life instruments in hand that we can use from 0 to adulthood, because they always have to look also or to remind the milestones and the developing changes human beings are undergoing. So just to come to the results, or to show what we had in hand. So about 660 patients participated in the 2008 in the quality of life assessment. And just to show one of the problems here, if you see from E1 and E2, you have similar numbers concerning patients, and then the participation decreased to about 30%. And we followed here the patients who did also the E1 and E2 and E3 and E4. So these are the patients that you can really compare in the longitudinal setting. Just to give you how this all happened. So we had 1,298 which were registered. Study patients were 906, eligible for quality of life 733. And then due to a lot of, exclusion issues, we had then in the end 303 who participated in E1 and E2 and E3. That means that these are the patients who really can compare longitudinally for the question of if this the treatment or during the course of treatment, how they judged their quality of life. So these are just the breakdown by the main participating countries, and those you could use the questionnaires. And you see here These are the, so 65% all in all participated in the quality of life assessment. And if you break it down then to all the patients who then had all of the different assessments, E1 and E2 and E3, this came down to 30%. So in the end, if you do a longitudinal comparison, you can only do it in 30% if you look in how quality of life changed after time. Just to show this again, how we made this. And now we looked into the data. So from the 303 study patients, there were a part who were not randomized and those who were randomized. And you can see here from the randomized groups, there were 120 in R1 and R2 in 20 and R3 25. There are always a bit of overlaps because you have in parallel completed self and proxy questionnaires. So there could be an overlapping also in age ranges. So to look now into physical functioning, just to use that what Miriam has said, that this is an important issue. And you see here the patients who were over 18, that would mean who filled the ERTC questionnaire. And these are the patients in the left who were not randomized and those who were randomized. And you see in both of the groups that during the course of treatment, there was an increase of physical functioning again, specifically then at time point 3, which is the deep green column. If we then divide into the 3 arms of randomized arms, you see here for the over 18 that there is a slight increase of physical functioning in the R1 group, and but which is not seen in the R2 group. This was the pulmonary metastasis, but we also have to take into account that this arm was closed earlier. And then you have the group with the R3 randomization. And here you see also an increase of the physical functioning of this group at the time point E3. If you look this into the smaller patients until the age of 18, the picture is a bit different. I just show here the increase of physical functioning in the non-randomized and in the randomized group altogether, and then again divided into the randomized patients. And you see here that in all of the groups, regardless if they were in the randomized R1 or 2 or 3 group, an increase of physical functioning, which was more markedly in the R3 group and in the R1 group. We looked also into the parents, and you see parents normally always vote or judge the quality of life of their children more impaired than the children often do themselves. This is a general observation, but also you see here that if you compare the patients' ratings in the randomized group and in the non-randomized group, in both groups, they also say at E3 that their children have a much better physical functioning than in the beginning. And this is also what in the randomized R1 group we see. I put this here in a kind of blurred scale because the numbers in this R2 and R1 group for the proxy ratings are very small. So I do not want to draw a conclusion from this. So what can we say? We can say that there are minor to moderate trends from improved quality of life rating related to physical functioning at S3 compared to the other 2 time points. And this is throughout all questionnaires. And the mean values are between 10 to 15 points. We have not looked specifically into the statistical relevance because we had to do this for all the domains, and this would really be breaking here the limitations of this talk. And but it would gives an up-to-date of what we can learn from the Ewing 2008 in terms of this domain. What will we do in the future? There's always a problem in handing out questionnaires because you need other people to bring it to the patients and to collect it. So what we want to do is now we want to use the new media also to reach the patients and give them the possibilities to do online assessments. And this I did not mention here, we know that specifically other functional outcomes and fatigue are playing an important role. I did not target this here in my talk, but we could already say from that what we have in our results that fatigue is a major problem specifically in the long run of these patients. But in adolescent patients, this is a problem occurring already during the course of treatment and might last then, if not without other interventions such as physical activities or other activities that Andrea has shown so brilliantly, really need to be added to the normal so-called medical treatment. And with this, I want to stop my talk. Thank you very much for your audience, and hope that you can get some of the information as useful for further discussion. Thank you.
Thank you, Gabi, for this brilliant talk in the context of quality of life studies in the Ewing 2008 trial. I probably have a few questions for you. I was wondering, when you're showing the evolvement over time, have you run the analysis with including all the time points, or did you then, since some patients progress and one could say there's this impairment in the beginning of the treatment and then they simply drop out later on? Have you looked at this population who actually made it successfully through the treatment and to see them probably as a less biased population?
Yes, this is correct. If we do it longitudinally, you can only use the patients who then stayed during the course of treatment. So it would be important to know if you, the point is, the E3 point is at the end of treatment. So at this time point, you do not include the relapses and the recurrences because they have happened then in the year after. So it would be important to see this specific aspect, as you mentioned, if this impacts also then retrospectively, and that you can say that they do not do as well as the others. So it's an important question.
And along these lines, what's your vision on patient-reported outcomes? Since we are talking lots about it, and if we see the high dropout rate over time, I think obviously patients are sort of happy if they get out of treatments and can return towards a healthier life or a recovery. Have you had sessions or talks with survivors what potentially could make patient-reported outcomes more attractive with future tools?
Yes. So I think they are all now on media. So the media is important, and we have to have kind of, you can say, possibilities that they get a kind of, announcements, that they get a kind of push up like we have in WhatsApp or something, so that they are reminded in a way, or that it's easier for them to access it, and that they can also use it not only as a single, you can say, as a single issue. So I would say if you talk about patients' reported outcomes, we have to find a way to get their interest not only in answering questions, but that they also get information through it that can help them maybe better to, as I said, as Miriam said, to be active in sports, to do better, to eat better, to have other things that makes them really feel connected, and also that they feel that we understand what they need. So it must be an interactive issue. It's not only something that we just ask them to answer questions.
Yeah, I think that responds very well to your question mark in your title. Yeah, it's more than a questionnaire. And I think there are lots of opportunities, and even referring to the previous talk and the favorable input of activities, be it physicals or others like Andrea mentioned previously in his talk. So I think we probably can do lots with modern media if we do it multi-professionally together, and particularly with the patients and the survivors. So thank you very much. And I think we will have opportunities. This just one word that we pushed quite hard on the Cancer Mission Board, that we have this holistic and very encompassing view on patients and needs all along the cancer journey. And I think for everybody, something will be in the course to come, I hope, yeah. And the first things I saw look quite good. So I hope this offers really opportunity to our whole pediatric oncology society and all the interactions that we have with adult oncology. So Herbert, I hand over back to you.
Thank you, Ruth. We are now coming to the final presentation of this wonderful meeting. Who doesn't know Lars Jott? Lars is the director and chairman of pediatric hematology and oncology of Lund University in Sweden. He is the inventor, the face, and the chairperson of PanCare, and PanCare stands for the Pan-European Network for Care of Survivors After Childhood and Adolescent Cancer. And Lars will now present this network to us. Thank you very much, Lars, for being here.
Thank you very much, Herbert, and thank you to the organizers for inviting me to this amazingly efficient and good meeting. So I will present PanCare to some extent, but I tried to mention some of the late effects in Ewing sarcoma that are important, I think, to remember and be aware of. Next, please. And the next one. So this is obvious to everyone that without cure, we don't have any late effects. Next one. So what are the possible late complications that can occur? So there are cardiovascular, for instance, heart failure, cardiomyopathy. If you add radiotherapy to that, you also affect the coronary vessels, the pericardium, and the valves. There's the risk of second malignant neoplasms, for instance, breast cancer after radiation therapy to the chest, where the breast is included in the radiation field. Pulmonary problems, infections that can come, for instance, after surgery or radiotherapy to the chest, which creates locus minoris, places for infections. And there can be neurologic problems because of paresis or epilepsy and so on. Not so common in Ewing sarcoma late effects are the endocrine problems, but if there is radiation to where glands and so on are affected, then of course there can be a problem. And there are neurocognitive issues, mostly related to brain tumors and other treatments that affect the central nervous system. Next, please. There can be renal problems that can be due to either radiotherapy or surgery or chemotherapy. And in Ewing sarcoma, we often see these functional outcomes and physical performance being affected, everything depending on which part of the body that was the site for the disease. Gabi has eloquently mentioned the quality of life issues. And the big issue, I think, in Ewing sarcoma is infertility, because we are giving a lot of drugs that potentially can affect both fertility and in women lead to a premature ovarian insufficiency, meaning that their reproductive window is more narrow than for others. So counseling that you shouldn't wait too long if you want to have children is important in this group. And auditory is mostly then related to the platinum agents, so that's not an issue in Ewing sarcoma. But if you have radiotherapy for some reason in a Ewing sarcoma where the auditory system is affected, you can of course have problems there as well. Next, please. So these are the cumulative doses of the compressed VDCIE versus the VIDA plus VI or VAC. So you can see the different doses. And basically what we do if we choose one or the other is that we simply move the toxicities around a bit. They're very equal, I would say, in treatment efficiency. But if you have more cyclophosphamide and if ifosfamide, you will increase the risk of infertility problems. And for ifosfamide, the kidney problems with this huge dose when we give 8 VI cycles post-operatively. A little more etoposide in the VDCIE compressed regimen might increase the risk for secondary malignancy somewhat. And unfortunately, we still have the high doses of doxorubicin in both these protocols. And I think the difference between 360 and 375 is probably marginal. Next, please. So what can happen with different drugs that we use then in Ewing sarcoma treatment? With vincristine, there's the risk of peripheral neuropathy. Ifosfamide, we mentioned renal problems and affected sex hormones. Doxorubicin, again, with on its own cardiomyopathy, but then it's also been linked to second primary neoplasms in solid tumors. Etoposide, second primary is mostly myelodysplastic syndrome or frank AML. Cyclophosphamide, again, infertility and also linkage to second primary neoplasms. Actinomycin D is sometimes mentioned saying that there are no late effects, but there are also maybe some evidence that there could be liver problems, especially if you've had toxicity such as VOD during treatment. Busulfan will give lung problems, infertility, and again, the affected sex hormones. Melphalan, similar problems. And treosulfan, I haven't really found any information on long-term effects, but maybe it's reasonable to at least be saying that it could be similar to busulfan so that we don't avoid informing our patients about these things. Then radiotherapy, and it all depends on what you're giving radiotherapy to, the volume, the dose, and also the fractionation. We have patients in our late effects clinic that many years ago received 10 grays of total body irradiation in 1 fraction before they got their stem cells back. And that gives a lot more problems than those who have had TBI in a fractionated way. And the younger the person is who is irradiated, the bigger the issues, at least when it comes to hypoplasia in the irradiated site. We've all seen those that were irradiated to the face for, let's say, a rhabdomyosarcoma or to the kidney region. And it's very, very striking how the hypoplasia can play a major role in not only quality of life, but also with frank medical problems. Pulmonary issues, of course, if you irradiate the lungs, and if it then add surgery to that, that's another issue. We have a functional asplenia. If we irradiate the spleen with enough, with a reasonable dose, there is the risk of functional asplenia, which means that these patients, should they become infected by a capsulated bacteria, they could get very, very sick. Cardiovascular problems, like I mentioned, if you irradiate the chest and the heart, is in the field of irradiation, you do add coronary problems valvular problems, and pericardial problems. And one of the major cardiovascular causes of death in late mortality after treatment is coronary infarction. And then again, like I said, other problems depending on the irradiated area and possible risk organs. And sarcomas are very peculiar in this sense compared to adult malignancies, because they don't respect organ boundaries. They go pretty much wherever they want to go. So whatever area you may have to irradiate is pretty much unique for each patient, because it's not that it's a uniform presentation or disease. Next, please. So I'm going to present some of the data from PanCARE-SURFUP, which is a pan-European study in FP7 that we conducted between 2011 and 2017. And we are coming out with more and more information now on the treatment and the effects it had. So this is a paper on the risk of digestive cancers in almost 70,000 5-year survivors in Europe. Next, please. And you can see that the standard incidence ratio for any digestive second primary neoplasm is 3.4. That is, it's 3.4 times more likely to have a digestive cancer compared to what was expected in the population. And basically it goes from your mouth down to the rectum. And again, sarcomas can have a lot of these areas included in the field of radiotherapy. So creating follow-up guidelines for this will be challenging, but I think it's important to know about this so that if you have a patient and you know pretty much what area was irradiated and he or she has complaints, you should be aware of this increased risk. Next, please. And you can see in this, it's a bit difficult, but it's Wilms tumor on top and then lymphomas, mostly Hodgkin lymphomas, that are the big problems here. Ewing sarcoma would be included in the red, the yellow line, which is other. But I think we give high doses of radiotherapy to our Ewing sarcoma patients when we do give them radiotherapy. So I think it's likely that we will have issues with second primaries in the field of irradiation there. And to the right is the cumulative incidence of a colorectal second primary as a function of attained age. Next, please. So here is another PanCARE-SURFUP study with the risk of cardiac ischemia in almost 37,000 childhood cancer survivors. Next, please. And you can see here that it's lymphoma, the red line, that is leading as a cause of cardiac ischemia. But you see the purple line, that's bone and soft tissue sarcoma. So by 60 years of age, there will be 6% of cardiac ischemia issues in bone sarcoma patients. Next, please. And just to end, saying that there are PanCARE follow-up recommendations coming out for pragmatic follow-up of pragmatic guidelines, I should say. We have had guidelines from global corporations like the International Guideline Harmonization Group, and together with PanCARE and others. And in the project PanCARE Follow-Up now, there is a work has been done. So we now have, sorry Utta's text. We now have guidelines even for those things that where there's not enough evidence to have evidence-based guidelines, but we've made pragmatic suggestions for this. So thank you. I know I'm standing between you and the rest of the day, so I'll try to make it as quick as possible. Thank you.
Thank you, Lars, for your excellent presentation and important data. Are there questions, remarks? I think we come to the end of this symposium, and before
I have posted one question.
Yeah, I think what your question is important, and if we look at what the Americans say now in the COG guidelines, if you've had radiotherapy to the gut, where at least the large intestine is included, they recommend colonoscopy from age 30 and at least 5 years of therapy. So that means every child has then, when they're 30, has had that latency period. And we've actually started doing it in Lund for our patients now, even if it's not yet recommended in Sweden. And we found both adenomas and frank cancers, real cancers as well, in patients where there were no symptoms. So I think it's reasonable to do this if you have these large doses where part of the abdomen is in the field of irradiation.
So any Ewing with pelvic irradiation or only retroperitoneal diseases?
I would then suggest that you do what we do. We go to our radiotherapy doctors, ask them to tell us what kind of doses were given to different organs, kidneys, large intestine, etc. And if it's presented by them that there is enough of the gut in the field of radiotherapy, then I think it's reasonable to do it.
Many thanks.
Okay, I think we come to the end of this symposium. And I think before I hand over to the closing remark session, I think we should all switch on our cameras and give the organizers a big applause. This includes Uta Dirksen and her team, and this also includes the team of the German Cancer Foundation, Michaela and her team. I think they deserve this. It was a wonderful meeting and symposium. And I hope you made a picture. Uta, it's your turn now to say bye-bye to everybody. We don't want to go. We want to stay here for hours.
For the rest of the day. Yeah, it's okay. Fetch some cookies and we just have some mingling time, whoever would like to. I mean, this is what we were missing. So thanks so much for everybody who participated in the meeting. It was, the title was like Learnings from the Past, Challenges for the Future. And I think we really made the floor for and showed the young research that there's still a lot of room for more research, more patient care, and a lot of room also for global collaboration in this very rare disease. So thanks to you, and a very special thanks goes to Helena and Mike and Ornella and Yasmin and Zoe for raising the patient's voice in a very touching and comprehensive way, and of course to SPAN and DSS that constantly help to raise the patient's voice and bring patients into our networks, and I think we can really learn a lot from them. And with this, I really again would like to thank our wonderful team who stayed here with us the whole day to do troubleshooting and whatever. And we just posted yesterday some champagne and beer pictures via WhatsApp. It would have been really great to if we would have had the opportunity to go out together, have some mingling time, but I mean, as medical doctors, researchers, and also patients, we all know that we are always full of hope and full of trust that better times will come. And yeah, with this, just thanks a lot to you all, and I wish you a wonderful rest of Saturday and Sunday, and really hope to see you all in person at least next year. Thanks a lot.